All right, we're going to start the first case
Okay.
at Cockerell
Hi, guys.
Dermatopathology. It's Dr. Ray. I'm here to help you get through this, and we're going to make it so easy. Make this easy. So we have a beautiful punch biopsy. And some of you are already guessing what's going on, and you've got a fix on this, and you're honing in on where the action is on this biopsy, which is very much in the panniculus. And some people say to me, Dr. Ray, I really don't understand what you mean by septae and lobules. And I think here is a beautiful example where we can see a beautiful septae, and we have a beautiful two lobules here, and then possibly another septae here and another septae here. So right away, we're looking up here, and this the action is, there's a little bit of action in the superficial dermis where we're seeing a perivascular inflammation. But we can see pretty much the epidermis is uninvolved in this process, and the referring dermatologist got an excellent biopsy here, and they got very much deep into the panniculus. So we really need to focus our attention on what's happening down here. And we're seeing a lot of thickening here of the septae. We're seeing this sort of a fibrinoid look, a widening of the septae, which is due to fibrinoid change and edema, a little bit of increase in collagen in the area. And we notice that it seems to be mostly chronic inflammation. We're not seeing much acute inflammation. We're not seeing many neutrophils or eosinophils. Mainly we're seeing mononuclear cells, lymphocytes, histiocytes. And as we focus in on higher power, we can see that some of these histiocytes have a little bit of foaminess to their cytoplasm. Some of them look a little bit epithelioid, meaning they look like epithelial cells. We see a little bit of increase in the blood vessels. And we see a little spillage from the septae of the inflammation into the lobules, but not enough to call this a lobular panniculitis, but there's some spillage into the lobule. You could almost say these are lipogranulomas because these histiocytes that are foamy are surrounding the fat, the adipocytes. So that's the definition of a lipogranuloma. In other areas, we're seeing granulomas around these sort of slit-like vascular spaces. I'm trying to find a good example of it. Here we have some vessels. We have some giant cells, which are foreign body type giant cells. I'm trying to find the so-called Misch's granulomas, and they're not, wholly apparent because they have a radial appearance, and we don't really see that where they kind of radiate out like the spokes in a wheel, and we're really not seeing that here. So we mostly have little areas of collections of histiocytes that are not very well-formed granulomas. They're not case-eating. They don't look like the type of granulomas you'd see in tuberculosis. When we get these septal panniculitides, and we see this many giant cells, we tend to do the infectious stains. We do the stain for PAS and FITE, and we'll even do a GMS as well to pick up, even better pick up the fungal organisms that might be there. So we definitely want to stain these, and once we stain them, and if it is sterile, we don't find any organisms, then we need to think about a septal panniculitis, and one of the key septal panniculitides is erythema nodosum. So let's discuss erythema nodosum and see some of the key features. Oh, loading very slowly. So you have a panniculitis with a mixed acute chronic inflammatory cell infiltrate, septal fibrosis, and minimal vasculitis. You can see some vascular changes, but typically you don't see vasculitis. But if you do, it usually be in small vessels, and sometimes they'll just be lymphocytes. There's foci of macrophages and multinucleated giant cells in the septae, and the cause of this inflammation is not evident. When you do your special stains, they all are negative. You can still say this is erythema nodosum. EN is a relatively non-specific hypersensitivity reaction and a diagnosis of exclusion associated with a variety of causes. Strep infections are the most common etiology in children, and sarcoidosis, drugs, inflammatory bowel disease are most common in adults. So if we do see granulomas, and we did see some ill-defined granulomas, we do our stains, and our stains in this case were all negative. You can even do a gram stain and look around for organisms. Typically, you don't find any organisms in these in erythema nodosum. Misch's granulomas, again, is that cluster of macrophages around a small blood vessel or slit-like space. I did find one, but it was harder to go back and find it again. So they weren't really prominent Misch's type, but there were little granulomas. Clinically, you'll see crops of tender red nodules. If they're non-tender and single, consider folliculitis or a ruptured cyst or even trauma. So typically with EN, you'll see more than one nodule. They can be in the pretibial area, the shin, the calf, thighs, forearm, and hand and face are more rare, but you can occasionally see it there. I have seen it on the extremities. Arthralgias, you can see that in 50% of the patients. EN is associated with systemic disorders such as they're associated with it with sarcoid, ulcerative colitis, Crohn's, inflammatory bowel disease, lymphoma, Hodgkin's, Behçet's, polyarteritis nodosa, Sweets syndrome. So there's associations with them, which doesn't necessarily mean you'll see Sweets atop it, but there's an association. Bacterial infections, post-strep infection, TB, leprosy, syphilis, leptospirosis, Yersinia, salmonella species infections. All of these you can see associated with EN, viral, chlamydia, vaccinia, cat scratch, LGV, glandular fever, infectious mono, psittacosis, fungal infections, blastomycosis, coccidiomycosis, histoplasmosis, dermatophytes, drugs. You'll see erythema nodosum associated with OCPs, barbiturates, sulfonamides, halogens, hormonal causes, and such as pregnancy and contraceptive pills. All of these are associated with EN. So keep that in the back of your mind when you get that diagnosis histologically from your pathologist. The next case we're going to discuss, as far as I wanted to mention just briefly, induratum, as you know, is a lobular, more of a lobular paniculitis. So keep that in mind. That isn't a differential. But if you see more of a lobular process, start to think about induratum. The next case I wanted to show you is this punch biopsy where we have a lot of hemorrhage you're noticing right away that seems to be taking up most of the upper and lower dermis. You're seeing red blood cells scattered throughout this, this inflammatory process. Right away, the epidermis doesn't have much involvement. Most of the action is in the superficial mid and a little bit into the deep dermis. So this is a very widespread lesion. And if you go on higher power, you start to notice that there are lots of neutrophils scattered throughout. And you're also noticing that a lot of these capillaries look funny. They look sort of smudgy. You can't see the lumen on many of them. Some of the endothelial cells look swollen, enlarged, but not atypical. They don't look atypical, but they do look enlarged. You're also seeing karyorrhexis, which are these broken up neutrophils. Right away, when you see this karyorrhexis, you start to think about, well, could this be leukocytoclastic vasculitis? And then you want to take a count of how many eos there are, and we're not seeing many eos. Most of these cells that are lighting up here, very eosinophilic, are the red blood cells. So you want to look to see if you can find fibrin in these vessels. Sometimes you don't always see it, but there's a lot of smudging, and there's some fibrin in the walls of many of these vessels. The process that causes this is that you have leaky capillaries, and these capillaries get leaky, and then the neutrophils come out of them, and that's why. And then the neutrophils break up; they release enzymes and break up. So that's why you're getting such a messy look to this slide. So when you start to see karyorrhexis, right away think about leukocytoclastic vasculitis. I'm trying to find fibrin. I did find it last night in some of these vessels. Sometimes it's difficult to see on this power, but you can see the endothelial swelling in many of these capillaries, and that's definitely a sign that something's happening to these vessels. One of the things you want to look for in these endothelial cells is you want to take it up as high a power as you can and look in the endothelial cytoplasm to see if you see any bacteria. It's very important that you rule out a septic vasculitis, because that's the most important thing you need to rule out histologically. Sometimes we'll do a tissuegram stain or a Brown and Bren to see if we can see the bacteria, because that's an important differential that you have to exclude would be septic vasculitis. And then you'd go off and start thinking about Neisseria or gonorrhea or rickettsial or even staph as a problem. So in this case, it was a sterile biopsy. We didn't see any bacteria in here, so we ruled out septic vasculitis. So that's really important on a test that you look in those endothelial cells, or you look even in the lumen to see if you see bacterial emboli. Typically, the cases I've seen it's been in the wall of the capillaries. So we did not see that here, so we're able to eliminate septic vasculitis. And we're not seeing any large vessels down here with inflammation, to think about other things like polyarteritis nodosum or something. So we're not seeing any large vessel involvement or medium to large size vessels. We're just seeing most of the action in the dermis. So this was leukocytoclastic vasculitis. You'll get tested on this. In the dermis, there are lymphocytes, neutrophils, the dust, which is the karyorrhexis of the broken up neutrophils, extravasated erythrocytes. That's why it has the palpable purpura look clinically. There's fibrin in the walls of the small blood vessels, relatively low infiltrated leukocytes, militates against, but does not completely rule out sweets. So you need to think about sweets, but you'll see many, many more neutrophils. You'll see more of a diffuse process of neutrophils. And then again, bacterial organisms are not conspicuous in the dermis of the vessel lumen, so therefore you can rule out septic vasculitis. So the most common type is the palpable purpura. You get variable numbers of eosinophils. Now, if you start to see a lot of eosinophils, start to think about drug as a possible cause. And we didn't see many eosinophils there at all. The differential includes sweets, and you'll see much more papillary dermal edema. We didn't see any papillary dermal edema there. The infiltrate of neutrophils is usually more intense in sweets. And typically, the vasculitis is very hard to find. It's supposed to be there, but it's very hard to find. And there's no significant fibrinoid necrosis. Extravasated reds are not conspicuous as an LCV. Again, the infectious LCV, which is really septic vasculitis, you'll see on gram stain and fungal stains, you'll see organisms. Leukocytoclastic vasculitis, it's seen in many, many entities, and you really need to commit some of these entities to memory, like a hypersensitivity vasculitis. Typically, you'll see that on the legs. Granuloma faciale, obviously on the face, you'll see more eos and a Gren zone. EED, erythema, diutinum, I can't think of the middle letter right now, but EED, typically on the hands and knees, extensor surface and buttocks, you'll see that onion skinning, fibrosis, and granulation tissue in the chronic EED. So elevatum diutinum, that's it, erythema elevatum diutinum. But urticarial vasculitis is another entity. You'll see wheals and angioedema, and it's generalized, and it has a predilection for the legs. Rheumatoid vasculitis, you can see LCV in that. You'll see more large and small vessels, and the patient will be seropositive for rheumatoid arthritis. Palisaded neutrophilic granulomatous derm and rheumatoid arthritis, you can sometimes see LCV in that entity. Mixed cryoglobulinemias, you'll see the PAS positive precipitates in the superficial vessels. The patients, many of them are hepatitis C positive. Other patients may have leukemia, but some are hep C positive. Behçet's with the recurrent aphthous ulcers, occasionally you'll see LCV in that entity. And the list goes on and on. I can continue on to the next projection slide, and there's more on the list where you can see LCV. Henlock-Schönlein purpura, usually in children, occurs in occasionally in adults. It's typically on the leg, the buttocks, there's a purpuric rash. You'll sometimes see migratory arthritis, abdominal pain, hematuria, post-upper respiratory infection. On direct immunofluorescence, you'll see granular IgA and deposits in the vessels. So think about, if you have LCV in a child, think about HSP. Meningococcal septicemia, Neisseria meningitidis, and again, you'll see on immunofluorescence IgA in the capillaries. Lucio's phenomenon, leprosy, you can occasionally see it. LCV, disseminated Candida, you'll occasionally see LCV in AIDS patients, you can see that. Kawasaki syndrome, hypergammaglobulic purpura, polyarteritis nodosum, Wegener's granulomatosis, Scherg-Strauss syndrome, microscopic polyarteritis, you can occasionally see LCV, and paraneoplastic vasculitis, hairy cell leukemia after splenectomy, and drug-induced vasculitis with penicillin, sulfonamides, and eosinophils. You'll see typically with the drug-induced vasculitis, many more eosinophils and lymphocytes. So LCV can be seen in many, many entities, and you need to realize it's a reaction pattern that can be seen in many different diseases. So that was an LCV that we couldn't figure out the cause on the case that we had there. So, but you need to be thinking about when you get LCV as a diagnosis, all these different things that you can see it in. The workup of LCV includes doing cultures, throat swab for beta hemolytic strep, serology and ESR, and anti-streptolysin O, antibodies and PMNs. You'll typically see an increase in PMNs on your differential. So in a non-infectious etiology, you'll see systemic vasculitis. You might see hematuria, arthritis, myalgias, elevated liver and muscle enzymes. And you might want to check the ANCAs, the ANA, the rheumatoid factor, the cryoglobulins, Hep B and C antibodies, IgA fibronectin aggregates, complement levels, and anti-C1q antibodies. And then there's allergic hypersensitivity reaction. You might check the drug history. So this is how you would work up an LCV for infectious and non-infectious etiology. Okay. Slide's taking a while. So when you get LCV and it's in a child, think about Henlock-Schoenlein purpura. The histology is identical, but then you'll see the IgG deposition on DIF will confirm the clinical diagnosis. But IgA positivity is not synonymous with the diagnosis, as IgA can be seen in other scenarios. Urticarial vasculitis, typically you'll see more eos. The changes can be very similar. Typically there's more prominent superficial dermal edema, and there's the density of leukocytes is a bit less. There can even be less neutrophils, but you'll see some eos, and that's the tip off that it's an urticarial vasculitis. Septic vasculitis, you'll see a vascular occlusion by a thrombus occasionally, and there'll be there might be very little leukocytoclasia, but you will see occasionally the bacteria in the walls or the lumen. Sweet syndrome, you'll have conspicuous papillodermal edema, typically not many extravasated reds, and a more intense neutrophilic infiltrate. Our next case, we have an expansile mass. Let it get into focus. It's taking a little bit of time. So we have this expansile mass that's a large zone of uninvolvement between the epidermis and this mass that's in the lower dermis and the subcutis. This was a punch biopsy, and the mass just was very expansile. When it was pulled out, it just was a nodule. Just because it seems somewhat well circumscribed, it doesn't necessarily mean it's benign. Because when we see this degree of basophilia, there's a very, very high amount of cellularity. And when you see this degree of cellularity, you're very, very suspicious. So on low power, you should be thinking, hey, something's wrong. This looks malignant. And when you hone in on higher power, you're seeing huge, huge cells and mitotic figures. I mean, this cell with 3 nucleoli, if we find a normal lymph, if we can even find one in here, this is a huge, huge cell. And there's a great degree of variation in size and shape of these cells. There's also vesicular chromatin and very, very prominent nucleoli and mitotic figures, many mitotic figures. So right away, this is a malignancy. There's clumping to these cells. They're not discohesive. If they're discohesive, you start thinking about lymphomas. Even things like an anaplastic large cell lymphoma, the cells will be discohesive. They won't clump like this. And because they're clumping together and they're sticking together, you think about a process that's more epithelial, and a process you think of more about a carcinoma in this case. And we don't see any melanin pigment. So yeah, well, you got to think about a melanoma for a second or two. Of course, you can look for melanin. And also you want to look for any signs of differentiation. Do I see any keratin pearls? Do I see any chunks of keratin here? Or the tumor having an eosinophilic cytoplasm? But what I am noticing is I'm seeing some vacuoles. I'm also noticing what looks like a punched out look to some of these vacuoles. And that's making me think that this may be forming a little bit of a gland. So it's got some differentiation here, and it's forming glands. And it is subtle. And you may see this and say, well, no, that's not a gland. That's more of a vacuole. That's really maybe a little bit of a gland there, because you'll typically see what looks like a little basement membrane here around the inner aspect of the lumen. So you need to just look around and see. And as you keep looking, you'll notice there are a bunch of these little glands. No, that's not one. That's not one. No, no, that looks like just necrotic cells. So you're seeing, here's another gland right here. So what you're seeing is gland formation. And when you see gland formation and the cells look epithelioid, you start thinking about adenocarcinomas. And when you see an adenocarcinoma in the skin, don't jump right away and say, oh, this is some kind of malignant adnexal tumor. That's it's less likely than it being a metastasis. So when you see an adenocarcinoma in the skin and you get the diagnosis on a path report of metastatic adenocarcinoma, this is what it looks like. This is what you would see. And that's when your differential has to broaden to anything systemic and where this could be coming from. We have to figure out right away where this is coming from. And the clue is, well, where is this on the body? It was on the chest, and it was on the chest of a man. So right away, if this was the chest of a woman, you start thinking about breast cancer. But if it's on the chest of a man, breast cancer is going to be less likely. Now, I'm not saying it's completely unlikely, but it's much less likely. So this was on the chest of a man. So breast was in the differential, and now that kind of puts a little bit lower on your list, and you start thinking, could this be from the lung? Could this be an adenocarcinoma metastasizing from the lung? Now, this is in small cell carcinoma because these cells are large. I mean, it's very simple. These cells are large and they're not molding. So that way, you're going to rule out small cell carcinoma coming from the lung, and you're going to think more about adenocarcinoma coming from the lung. This doesn't look like squamous cell carcinoma coming from the lung. We don't see any keratin. We don't see any intercellular bridges. And we see gland formation right here. Glands are all over the place. So lung is in there and colon is very high up on your differential. And you might want to give, you might want to, if you get metastatic adeno as a diagnosis, you might have right away asked the patient, do you have any, primary cancers going on and in your past? And then they will tell you, and then you can tell your pathologist right away, or your pathologist is already working it up and doing innumerable stains. Well, I did a stain on this. I had no idea where it was coming from. And I did this TTF stain, which is thyroid transcription factor 1. And you're like, wait a minute, it says thyroid in the name TTF. Is this coming from the thyroid? Well, if this was coming from the thyroid, we would see colloid. And we don't see colloid here. And we don't see Samoma bodies. And we don't see other features that would make you think about thyroid. When thyroid metastasizes, it tends to keep some of its differentiation from its original organ. So you'll see glands, and then you might see pink eosinophilic material in them, so-called colloid, if you remember what thyroid looks like histologically. So thyroid, we're going to put that on the back burner a little bit, and we're going to think more, could this, that this is probably coming from the lung, because the TTF1 is positive. It's on the chest. It's in a male. He is a smoker. And they're giving him a CT to see why he's having shortness of breath. So they think he may have a nodule in his lung. And with this TTF positive, you can definitely let your dermatologist know that you suspect this may be coming from the lung. Also, you can do other stains, and we're going to go over those stains, the other stains we can do to further confirm it. Remember, we're just confirming it. We're getting closer and closer to the final answer, but you're always getting closer and closer. Can you prove it 100%? Well, if someone has a big lung nodule and you have a bunch of stains that are typical for lung, like the CK7 is positive and CK20 is negative, and you have this TTF1 is positive, and you can do other stains, and we're going to go over those. In this case, the 7 was positive, the 20 was negative, the TTF was positive, although occasionally the TTF can be negative with lung, and your napsin A was positive. So that led us to the idea that this is most likely coming from the lung. In fact, they did work up the patient and they found lung cancer. So this is a metastasis. So what we do in pathology is we do look at how common these metastatic lesions are by sex. Like in females, you're more likely to see breast, colon, lung, ovary, melanoma in that order. Male, melanoma will be first to metastasize most commonly in men, and then lung, colon, oral, larynx, kidney, stomach. So that helps us kind of hone it in on what we're most suspicious of and we're working on. In this case, the SOX10 and the S100 were totally negative, and that ruled out melanoma completely. Other lesions that metastasize rarely: thyroid, pancreas, liver, gallbladder, urinary bladder, endometrium, prostate, testis. Testicular tumors. Lymphoma, well, the CD30 would have to be positive, and the CD4 would have to be positive, which is a T cell marker. And the CD30 is for the anaplastic large cell lymphoma. And this didn't look like lymphoma because the cells weren't discohesive. And this did not look like what we would typically see with leukemia cutis at all. This is just not the pattern for that. So we can pretty much eliminate that possibility. So in this case, it was metastatic lung adenocarcinoma. Next case, we have a punch biopsy that very much fragmented, and it looks like we have 4 sections here. This is almost, well, 2 sections, 2 levels and 2 sections. This was probably a punch bisected, and then it fragmented apart, and they're laid right so very close to each other. So this tumor is fragmented, but the cells are sticking together, but the pieces themselves fragmented, and it may be due to the processing. But we notice a large zone of inactivity here between the epidermis and this fragmented tumor. And you may be saying, my gosh, Dr. Ray, this looks like the last tumor. Nope, it's different. When we get on higher power, we start to hone in on what these cells are doing. And right away, we notice that these cells have more of a spindled appearance. We notice a very high mitotic rate. We notice the spindled appearance is very, very important here. You see how these cells are more spindled. They're running in this direction. And you can see in certain areas the spindled appearance. And right away, you're like, well, this is a malignant spindled cell tumor. I can see the spindled cells. I see mitoses everywhere. I see dying cells. Very, very high NC ratios. I cannot see the cytoplasmic borders. When you cannot see the cytoplasmic borders, you move away from an epithelioid neoplasm and you move toward a spindle cell neoplasm. So it's not only the fact that this is a more pointy cell over here, but the fact that you can't see the cytoplasmic borders. And that should help you determine that something is spindled rather than epithelial like the last tumor. And we can go back and compare. Now, this tumor has vasculature in it. That doesn't mean it's an angiosarcoma, because every tumor has to have a blood supply. That's how it stays alive and continues to grow. So we're seeing some vessels here, but we're seeing this spindled cell tumor. And the top of our differential, and you can really see it spindled here. The top of our differential is this an AFX. Is this, and when you think about AFX, you start to think about the pleomorphic dermal sarcoma, the malignant fibrous histiocytoma, and that group of entities. And then spindle cell melanoma, and you think about spindle cell squamous cell carcinoma. And because this tumor is so poorly differentiated, we have to do stains to figure out where these cells are, their cell of origin, so that we can better define this process so the oncologist will know how to treat it. Because if this is spindle cell squamous cell, it's going to be treated a lot differently than spindle cell melanoma versus AFX. So, and this is a very deep process. It was going into it pretty much overtook the lower dermis and it overtook the panniculus. Panniculus is gone. So we're going to stain this right away. And I had a suspicion that based on the way the cells looked, even though I didn't see melanin, I was very suspicious of a spindle cell melanoma, mainly because I saw some prominent nucleoli. And I know that's a very soft sign, but as we look on higher power, I did see some nucleoli in some of the cells. They weren't big red nucleoli, but I noticed the nucleoli were prominent and it was spindled. And I didn't see any differentiation toward squamous. I didn't see any keratin or anything like that. And then I wanted to go look at the epidermis overlying it, because whenever you suspect something might be a melanoma, always, always, always go above it and start looking along here and looking at these melanocytes and seeing if there's a lentigo maligna above it. And what we see is some exocytosis of lymphs for some reason. They're just going upward and nothing, there's no reason for it. They're just doing that. And we don't see melanocytes as being very prominent here. So I don't see MIS, melanoma in situ, atop this lesion. So, and with this large Gren zone, I'm starting to think, hey, this may be a MET. Could this be a MET spindled squamous, a MET melanoma, or could this be, well, AFX probably this would be, if this is so deep, it probably be more in line with a malignant spindle tumor like an MFH or even a pleomorphic dermal sarc, which tends to have much more pleomorphism than this tumor. This tumor, there's a uniformity to the cells, even though they're large and they have high NC ratios and they have nuclear atypia. So we did stain it, and we have a stain here, and our stain is for SOX10. And that helped me right away because it's a transcription factor involved in the specification of neural crest and the maintenance of melanocytes, the SOX10, that helped me realize that this is coming from melanocytes. So this is a spindle cell melanoma, which is a variant of melanoma. And I have to suspect that this was a metastatic lesion at the time of this biopsy, that it's coming from another site and it metastasized over here. Typically, these spindle cell melanomas don't like to go to lymph nodes, but they like to go to other parts of the body. So they're very strange in that respect. Now, why isn't this a desmoplastic malignant melanoma? Well, it's not a desmoplastic because it's missing the desmoplasia that you see in a desmoplastic malignant melanoma. You see a lot more collagen deposition, and you'd have to see greater than 90% of the cells surrounded by this dense collagenous deposition, the desmoplasia, to call it a desmoplastic melanoma, or else it's a mixed spindled and desmoplastic melanoma. So some people used to think they were closer, they were more similar, but they're both distinctive variants, but you can have a combined subtype is what I'm trying to say. So let's go to spindle cell melanoma and discuss it further. So you have these atypical spindle cells showing pleomorphic nuclei, high NC ratios, prominent nucleoli, that should be nucleoli, amphiphilic cytoplasm, the so-called amphiphilic cytoplasm that's neither basophilic nor eosinophilic. And mitoses are seen. There were a gazillion mitoses. I think I had to count at 10 to 20 per millimeter squared, which is a very high mitotic count. There was minimal melanin. These malignant spindle cell tumors tend to be amelanotic, and there was no attachment to the epidermis. So the differential is malignant melanoma, metastatic melanoma, AFX, pleomorphic dermal sarc, MFH, poorly differentiated squamous cell. Okay, someone might say, oh, Dr. Ray, why isn't it a DFSP? Well, DFSPs, I always say they don't look that ugly, and they tend to be more a storiform in their pattern. The storiform pattern, and I didn't see any of the Swiss cheese I like to see, and those little things help me. They help me every day. So, and you can put a CD34 on it, and the CD34 was negative, so it's not a DFSP. That's totally out. So here's your differential melanoma. In this case, S100 SOX10 pan-mel MART1, which is melan A. HMB45 can be positive in these, which is different than the desmoplastic malignant melanoma, which the HMB45 is either plus or minus, tends to be more usually negative. AFX, you'll see a CD10 positivity, procollagen 1, CD68, and your CD34 will be negative in AFX. They love to test you on that because of the close relationship where you're seeing the cells are somewhat similar. So remember DFSP is the CD34 positive, AFX is CD34 negative. They love to test you on that. And your keratin will be negative in AFX. Poorly differentiated squamous, you're going to see a positive pan-keratin stain, which is low and high molecular weight keratin, the so-called A1A3. And you can see P63 positive, P40 positive, CK5 and 6 positive. Those are some other more esoteric stains that people are using to determine that it's a squamous cell, especially when it's poorly differentiated. Spindle cell malignant melanoma. It's uncommon subtype composed of spindle cells. They're arranged in sheets and fascicles. It's challenging, this diagnosis. It may occur anywhere in the body, unlike desmoplastic, which kind of favors 54% of the time the head and the neck. So it frequently mimics amelanotic lesions like spindle cell squamous. Spindle cell melanomas are more commonly in Caucasian men, affecting men more than women, just about 2 to 1. So it's about 1.9 to 1 in some studies. And the average age of diagnosis 50 to 80 years old. One study with 4,000 patients, it was 66 years old was the average age. All righty. So, taking a while to load up. Spindle cell, yes. So I will show you a desmoplastic melanoma in the future so we can remember this and go back and look at it. Approximately 30% of spindle cell melanomas contain the BRAF mutation. The V600E substitution mutation is the most common. NRAS and KIT mutations are rarely seen. They love these questions on tests. It may first present as a widespread melanoma, a metastasis. In this case, it presented as a MET, this spindle cell melanoma. It's distinctly different from desmoplastic melanoma, and there's differences in the staining. The HMB45 is sometimes negative in the desmoplastic melanoma, which we'll see it's sometimes positive in the spindle cell melanoma. So that's one of the differences. And there's differences in the genetic mutations. Although the tendency for nodal involvement is low, the majority of spindle cell melanomas present in advanced disease. So you have to keep that in mind. This typically does not go to nodes, but it met somewhere else. It'll met to another part of the skin. You must look for other lesions too. When you get that diagnosis, you must look for other lesions. So that's really important. So now we have the next case, case 5. We have a shave biopsy. And right away we see a proliferation that seems to be involving the dermoepidermal junction, the epidermis, the junction, and involving the dermis, and we're seeing some inflammation. Right away, this lesion looks worrisome, but we're seeing somewhat of a symmetrical look to this lesion. We're not seeing a shoulder here. Now, when we look on higher power, we note that these are nests of very large nests of melanocytes, and we have over 40 to 50 cells in some of these nests. So these nests are big. But right away, we're noticing an absence of pagetoid spread, the so-called upward migration of the melanocytes. And that's a sign of malignancy. And we're not seeing that. And that right away, we're looking at this tumor and wanting to say, gosh, is this a melanoma? This looks horrible. These nests are huge. These cells look big, but they have a lot of cytoplasm, these melanocytes. They look somewhat uniform. And I'm not seeing any mitoses right now. I am seeing inflammation here, but maybe it's got a little halo phenomena going on. Maybe that's just getting inflamed. So right away, I got to look for my friendly cheminobodies, because cheminobodies are a sign of benignity, and I want to find them. And cheminobodies are those eosinophilic bodies, and I'm searching like mad looking for them. And as I'm looking, I'm noticing some melanin in this this melanocytic proliferation, and I'm not seeing many clefts. I'm looking for my friendly clefts. I like to see clefts because that is a sign of benignity in these lesions. So again, I'm searching at the same time, looking for the upward migration of these nests, even the nests upwardly migrating, or single cells migrating upward. And all I'm seeing are squamous cells. I'm not seeing melanocytes upwardly migrating. So that's making me think, oh, okay, this may not be a melanoma. This could be in a kid or something. I'm not seeing solar damage down here, severe solar elastosis. The slide is somewhat overstained, a little bit overstained, because I'm not seeing good eosinophilia to the collagen. As far as the vessels in this lesion, I'm seeing some vessels in here. Blood vessels, not a lot of them. I did find a cheminobody, and I've got to go find them because there was at least 2 or 3 of them. There wasn't many. And I think you know where I'm going with this. This is a compound nevus, and it is a Spitz type nevus because we have these epithelial and somewhat spindled cells. So you're having a combination of both epithelioid and spindled cells. It's a bit mixed in its type. Looking for those caminos. It must have been on another section, but we're seeing a lot of symmetry to this lesion, and we're noticing that it's in the dermis, and it's very important to look for maturation. And maturation means the cell size of these melanocytes are getting smaller as we go deeper. It is one of the signs that we need to look for. We also need to look very carefully and make sure there's no deep mitoses in these melanocytes down here. So you need to search and spend plenty of time with it to looking for any mitoses. And I searched very hard looking for mitoses. I'm trying to find that cheminobody, which some believe is made from basement membrane material rather than apoptotic cells. What is it, the type 4 and type 7 collagen? I found them last night. Let me guess, see if I can find another piece. Maybe it was up in this area. Let me look up here. Somebody sees one, yell out. Maybe you've already seen it. I missed it on this Zoom. All right, maybe. No, that doesn't look like a one to me. Perfect one. But you also see clefting. Sometimes between the epidermis and these nevus cells, you'll see clefting, and that's a good sign of benignity as well. Clefting, it's a softer sign. So the most important sign is the symmetry, the maturation, the lack of pagetoid spread, the lack of deep mitoses. All those are very, very important. And you have to search hard and make sure and look at the age of the patient. If the age of the patient is past puberty, you need to raise your index of suspicion for the possibility that this may be an atypical process and you might need to get it out. Because after puberty, you need to think about being a little bit more cautious and calling Spitz nevi. Symmetry, we're seeing maturation of the deep cells. There's sharp lateral demarcation, which was hard to see on that shade because it was in the middle of the process. There's no lateral pagetoid spread, no shoulder phenomena. Cheminobodies, you'll see those eosinophilic bodies, which were not many there, so it wasn't helpful. Junctional cleavage of nests, superficial multinucleated nevus cells, no deeper atypical mitoses, and epidermal hyperplasia. There was thickening of the epidermis. If we go back, you remember the epidermis was thickened and it was almost pseudoepitheliomatous, and that's a common thing that you see in Spitz nevi. There's junctional type, compound type, intradermal type, and there's spindle and epithelioid types and combination of spindle and epithelioid. And then there's subtypes. Some people think that the pigmented spindle cell nevus aride is a subtype. Other people think it's a distinct entity. I tend to think it's a distinct entity, but I added it here just to remind you of that entity because it mimics a Spitz and you need to be aware of it. Desmoplastic Spitz, combined Spitz and intradermal and nevus and a Spitz adulthood, you must consider a Spitz in adulthood, you must consider the atypical spitzoid neoplasm because you need to be a little bit more concerned if you're seeing a Spitz in an adult that possibly you're missing something. So what else can we learn about Spitz nevi here? Still loading up. Can we do any stains? Well, we can do an HMB45. And if we see a decrease in the staining as we go deeper, that's a sign that this may represent a Spitz nevus. So we can use HMB45 if you want to do a stain to help you out, and maybe a stain to even highlight if there were any pagetoid cells. Now, there is a pagetoid Spitz that does occur rarely where you will see some pagetoid cells. It's a very rare lesion, so not all pagetoid upward migration means instantly, oh, it's malignant. So you have to be very, very careful if you do see some pagetoid cells, if it's a certain type of Spitz that's pagetoid. So there is exceptions to every rule. Oh, it's not opening very quickly. Uh-oh, let me try again. Nope, it doesn't want to open for me. I may have to go to the next one. It's stuck. All right, we're going to go to case 6. We're going to move on from Spitz. All right, this is our last case for today, and I'm going to give you a sneak peek at the next case. But we have a well-circumscribed lesion here, very well circumscribed. We don't have any epidermis to look at, so we know that this lesion was either in the dermis or it was in the panniculus. As we go on higher power, we're very much struck by these tubules, these so-called glands, and some of them are branching. And we'll also note that there's a very prominent stroma here that's myxoid. We have this myxoid stroma. So there seems to be two components to this tumor. It's a biphasic tumor that's very well circumscribed and has a very much of a benign appearance, because when we look at these glands on higher power, we notice that there's at least 2 cell layers, but there's a bottom layer of myoepithelial cells. And that's a sign of benignity for these glands. And these glands are very regular looking. They look somewhat like they're eccrine. We don't see any decapitation secretion. Sometimes in these lesions, you can see some apocrine change to these lumina. But in this case, we're seeing more they look more eccrine. We also see this eosinophilic material inside the lumina. I'm not seeing, as I look throughout this tumor, right away I'm thinking about this, a type of tumor with two elements to it, a stromal element and an epithelial element. And right away I'm thinking about the so-called mixed tumor. And I always remember that because I see myxoid and I see epithelial and I think mixed tumor. So this is a chondroid syringoma. It was in the skin. It wasn't anywhere near the minor salivary glands or the lip or the face. It was in the skin in another location. I cannot remember the exact location, but this is a chondroid syringoma. So we have the two elements. We even have possibly some calcifications, which sometimes can be a sign of benignity because it's a long-standing process that's just, sitting here. And when we look at these areas that are epithelial, we notice that the cells have a benign appearance to them. We'll see an occasional mitosis, but it's nothing to worry about because the overall pattern of this lesion is well circumscribed, even somewhat of a little bit of a capsule, and it has a very benign appearance. It's not an infiltrative appearance, and the epithelial component is not, it doesn't have an atypical or malignant appearance, meaning high NC ratios, lots of mitoses, lots of nuclear atypia, just lots of atypia to these cells. The cells look very bland. So if you get an adenocarcinoma arising in this lesion, this chondroid syringomas, and it becomes, it looks more like an adenocarcinoma. So this is very benign. It doesn't look like an adenocarcinoma in any of these areas. So we can be safe, very much feel safe to call this a chondroid syringoma. And in this area, we are seeing the beginnings of a chondroid formation because these cells are looking like they're forming little lacunae, little chondrocytes, and it has a more solid appearance. I always think this looks more solid than these other areas that look myxoid. So here it's just beginning to start to form cartilage. And you can see ossification in these lesions as well. In this case, I didn't see any ossification, but that very much is a sign of benignity. When you start seeing cartilage in a lesion, usually it's a sign of benignity, usually. But you must look at the chondrocytes as well, these cells that are early chondrocyte-like, and see that they're not atypical looking either. So overall, this is a very benign appearance. But you should feel comfortable going on higher power and dispelling any thoughts that this represents an adenocarcinoma arising in a chondroid syringoma or arising in a pleomorphic adenoma. So that's it. And then the next case, oh, wait, I need to go over the didactic a little bit on this one. So chondroid syringoma, otherwise known as mixed pleomorphic adenoma or mixed tumor. It's a benign adnexal neoplasm, and most people think of sweat gland origin, although you can see some apocrine glands as well. It's a circumscribed dermal nodule composed of solid cords and duct-like structures in a chondromyxoid stroma. So it's consistent with the benign myxoid tumor, totally benign. Okay. Next slide. You can sometimes see cysts in them, chondroid areas, mucinous areas, hyalinized areas, osteoid matrix. They usually occur in the nose, cheek, upper lip, neck. External auditory canal is an unusual location, but it can occasionally be seen there. And then the malignant chondroid syringoma, you'll see necrosis, myxoid degeneration, pleomorphism, atypical mitoses. Duct formation itself with that myoepithelial layer rules out chondrosarcoma. So that's why when you see that chondroid, just forget about chondrosarcoma because you see duct formation. All righty, last slide. The differential of ecrine acrosporoma. Usually you'll see a predominance of a lobular epithelial proliferation, and you'll see a minimal stromal element. So you're not going to see those myxoid areas or those chondroid areas or those osteoid areas. And that's when you'd lean more toward it being an ecrine acrosporoma, and it's more lobular. You don't see just ducts It's kind of embedded in that myxoid stroma. And then there's the metastatic adeno. You'll see marked nuclear pleomorphism. As I showed you earlier, the metastatic adeno, there was nuclear pleomorphism. You're not seeing that here. And that adeno that we saw earlier was not well circumscribed. It had jagged edges, even though it was a round expansile mass, the edges were jagged. And necrosis, we saw necrosis throughout there, throughout that other tumor I showed you. And there were no benign stromal elements like cartilage and bone. So, and then with metastatic adeno, you should look for angiolymphatic. If you see that, it's a slam dunk that it's a malignancy. So that's it for today. And we're going to finish the rest of this in part 2 and go over the rest of the cases, because going over spindle cell melanomas and Spitz nevi are pretty extensive. I'm going to see if I can really quickly get back to that last slide really fast. I hope it opens. Yep. Okay, so we did talk about, going back to Spitz really fast, the stratification of HMB, where it decreases at the base. The staining of HMB 45 decreases as you go deeper into the Spitz nevus. And then the low PCNA ratio and the low Ki67, which is a proliferation index. And P16 is positive in Spitz and P16 is negative in melanoma. P53 is not significantly expressed in Spitz nevus, and there's a high expression of P53 in melanomas. So again, in a Spitz nevus, the S100 MART1 melan A are diffusely expressed in Spitz and Spitzoid melanoma. So those stains are not helpful. Remember that S100 MART1 and melan A are not helpful in differentiating a Spitz from a melanoma. They love to trick you on this. It's definitely test fodder, definitely. So know these markers. So this is a very important slide. So I'm giving you a chance to write some of it down. And you can always go back and look at these slides and also look these things up yourself to further verify it as well and check my notes. All right, thanks so much. vray@dermpathplus.com. Email me with any questions, complaints, concerns. And we're going to keep showing you more of these lesions. You're going to get it. You'll know it so well by the end of these courses. Signing out from Cockerell Dermatopathology. Bye.